Well, hello, everyone. Welcome to Samaritan's Purse International Health Forum. It's just a real pleasure to have you join us today. You know, in the midst of this pandemic, we just consider it a real privilege to have the resources and the know-how, the technology to be able to assemble together virtually from wherever you are around the world. So to begin with, if you would, you'll see the screen box to the right of your screen, or the chat box. If you'll just type in your name and perhaps your location so that everybody on the webinar can know who's joining us today. And also just want to remind you at the end, we'll have time dedicated to Q&A where you can use the chat box to present your questions to Laurie today. So before we get started, I'd like to just open us up in a word of prayer. So please bow your head with me. Dear Heavenly Father, we just thank you for this day, this winter day, Lord, and this is the day that you have made. And Lord, we're so grateful to you to be able to assemble together. Lord, that you couple medicine and ministry, Lord, just to present the gospel that needs to be heard, especially in the midst of this pandemic. Just speak through Laurie today, bless her, and just bless those that listen, that they may utilize this information to better serve. In Jesus' name. Amen.
Amen.
Well, again, thank you so much. I'd like to introduce our speaker today, Laurie Sauerwein. Actually, Laurie is quite busy right now. She is presenting to us from Caldwell Hospital in Lenore, North Carolina, where Samaritan's Purse has one of its two emergency field hospitals set up to help respond regionally to the COVID pandemic. And so she's really busy right now. So we just really appreciate Laurie taking the time out from her work there at Caldwell to present to us today. She'll be speaking about tackling malnutrition in medical missions, practical tips to improve outcomes. Laurie has been a registered dietitian for almost 40 years, working with people from multiple cultures, both as an outpatient clinical dietitian and a public health nutritionist. Laurie has quite an extensive background academically. She completed a master's in science and public health at the London School of Hygiene and Tropical Medicine. She also has her master's, of course, in nutrition from Central Washington University. Laurie and her husband, Mark, who happens to be a family practitioner, have had the privilege of serving many times with World Medical Mission, including a total cumulatively of 15 months in Africa. Both Laurie and Mark also serve on our international DART. So without further ado, I'll turn it over to you, Laurie, to present Tackling Malnutrition in Medical Missions, Practical Tips to Improve Outcome.
Okay, thanks very much, Lance. And I just want to say that it's been a real privilege for Mark and I to be associated with Samaritan's Purse for a number of years. Back in 1993, we called up Becky Williams, who was then the World Medical Mission program director, and asked her, can you send us to Nigeria, to a given town where our children could go to school, and we want to be there for an entire school year. And she said, we've never sent anyone out for that long before. But she was great and worked with us and managed to get us out there, seconded to SIM. And it was just a really great experience for us and our whole family. And since then, we've worked with Kathy Burleson and Gail Gamble and some of the others with World Medical Mission. So any of you that haven't gone out with World Medical Mission, I just really encourage you to do that, because it's been a great experience for us. And the reason I'm able to present today is because they worked really hard with us to find places for us to serve where there was some kind of a nutrition program or somewhere I could fit in as a nutritionist. So that is the reason that I've been able to have this experience, was their hard work. So next slide, please. Next slide, that's no disclosures. So the objectives today are just basically here to give you hints for the CME quiz at the end of this, if you're taking it, especially number 1 and 2. But the most important concepts from my perspective are the last 3. that you'll be able to identify patients most likely to be malnourished based on age and overall state of health, social circumstances, and diagnosis. Think about these things when you see your patients, and to be able to work with your local colleagues to formulate ideas for medical and dietary interventions, and that you'll endeavor to integrate screening and assessment and therapy for malnutrition into each interaction with the patient while you're serving overseas, and of course at home as well. And this is a large subject, so this is just going to be a very broad overview. Many of the subjects we'll discuss could actually be the focus of a course all by themselves, but I really love to do case studies, and I've had some really interesting ones when we've been serving, especially in Africa. And so there's some case studies and some stories, and I hope you'll get something that you can extrapolate to your own times overseas from these. Next slide, please. So 50 years or more ago, when we're talking about malnutrition, when you were going to go overseas, people would have pictures of underweight children, even starving, maybe children and adults you would think of when you thought about the word malnutrition. And now we know that there are multiple types of malnutrition. Malnutrition can also be overnutrition, overweight and obesity. Now we talk about the triple burden of malnutrition, where even in one country or one population, even in one household, there can be people with undernutrition, meaning they might be wasted or stunted, low weight for age, or the other person in the family might be obese, very overweight. Micronutrient deficiencies are now added, and it's called the triple burden of malnutrition when you have micronutrient deficiencies, because that's been recognized as critically important to health. So this slide is a bit complicated, but basically it delineates the overlap of the three types of malnutrition worldwide. UNICEF did a study, and in 141 countries that were analyzed, about 88% of these countries experienced more than one form of malnutrition. So that's what this slide is talking about. Next slide, please. So here's just a list so you can understand the importance of paying attention to nutrition when you're seeing your patients. The contribution of malnutrition to disease and mortality, that according to UNICEF, nearly half of all deaths in children under 5 can be attributed to undernutrition. And this translates into unnecessary loss of about 3 million young lives a year. And of course, different sources will give you different figures for all these that I'm going to read. But severe anemia is a leading cause of hospital admission and death for children in sub-Saharan Africa. They can have hookworm, malaria, schistosomiasis, thalassemia, on and on can contribute to anemia in children. 38.5 million children under the age of 5 are overweight, putting them at risk for overweight and obesity as adults, and then leading to, of course, diabetes and cardiovascular disease when they're a young age. In fact, working in a clinic in Yakima, Washington area, where we had a lot of Mexican-American immigrants, we were seeing children as young as 14 that had fatty liver disease. So it's just becoming younger and younger ages when people are starting to see the result of overnutrition. Globally, about 42% of pregnant women are anemic and 47% of preschool-age children. Now, what that means for you when you're serving overseas is this is an average. So in the US, it's probably lower, but overseas, it's probably much, much higher. So remember that when you're treating pregnant women, there's probably some countries, even 70% maybe of pregnant women are anemic. An estimated 422 million people have diabetes and 1.1 billion people have high blood pressure. So non-communicable diseases were responsible for about approximately 41 million of the 57 million deaths worldwide in 2016. And the burden is greatest in low and middle income countries, and 85% of premature deaths from NCDs happen in low and middle income countries. And of course, they just don't have the treatment that we do. So that's part of it. Diet is one of the 4 leading risk factors in deaths attributable to NCDs. Next slide, please. So what does this mean for you as a short-term health professional when you're serving overseas? What are some small but impactful actions you can take as you interact with patients and staff to reduce the impact of poor nutrition on population health? So of course, you're probably they're serving a short time. Most people don't serve like we did for 9 months, 10 months. Sometimes we've served for a couple months at a time. But even what you do when you're there for 2 weeks can make a difference as far as nutrition and the population health. So just to give some organization to my presentation, I'm going to try to discuss by age group. And I hope that my brief overview will give you some impetus to identify and address malnutrition in the patients that are in your care, and not just overseas, but when you're here in the States as well. So I do like to use case studies and tell stories. So I hope that some of this will illustrate why asking questions and relying on the cultural knowledge of your Indigenous colleagues is so important. Next slide, please. So here's the nutrients that are most likely to be noted clinically, more often by signs and symptoms, or they're known because of population studies. Proteins, notably high quality protein, meat and eggs, those kinds of things are quite expensive in many countries. And so people just don't have access to them. They might have protein as a vegetable source, but for high quality protein, not so much. Vitamin A, iron, iodine, zinc, folate. These are the ones that are noted by signs and symptoms often, but if these deficiencies are present, you can be sure that there are subclinical deficiencies of other micronutrients as well, and they're important. So they're not easily detected. Overseas, we don't have lab tests to check for most of these. Of course, you do for for iron and protein, you're going to notice, but other deficiencies is just lab tests are just not available. So you'll have to just know that this is going to be important. And if a person is underweight, if they're lacking in vitamin A, if they're anemic, they probably have other deficiencies as well. So when you look at your first few clinic days of patients, and even as you go out and walk around, which I hope you will do in the neighborhood of the hospital where you're working, you'll get an idea, even just by looking at the population, as to what forms of malnutrition might be prevalent. So be a noticer, be an observer. Are the people short? Do you see multiple children with thin or reddish hair? When I was in Haiti once, I saw a number of children. It was just almost unbelievable to me because we never see it in the States, but children that had rickets and they had the bow leg. And so it's just observe these kinds of things as you walk around. Also observe what foods you see for sale in the markets and in the small stores. You'll notice if you see the mostly indigenous foods, or if you're seeing all our Western junk food that we're importing to these nations. So next slide, please. With refugees and IDPs, if you work with those internally displaced persons, there's definitely a potential for further deficiency. So often these people come from situations where people were already on the brink of severe deficits because of drought, because of conflict, because of poverty, and they are probably on rations if you're treating them, because you'll be in a situation where they're in a refugee camp. But the rations they receive are supposed to be meeting international standards. However, sometimes the full ration is not available to people, or to the World Food Program even. They might not have it. They might not be able to get it to that area because of flooding or rainy season or who knows what. But the people also sometimes sell or barter parts of their rations for other items that they think are more important, because they don't realize that you need to have the whole gamut of the ration in order to have good nutrition. So just be aware that if you're dealing with people who are relying mostly or solely on food rations, that they're at very high risk for malnutrition. And there are even documented cases, not only of the typical vitamin A and anemia deficiencies, but there are documented cases of pellagra and scurvy in ration-dependent populations. So just be aware of those things. Next slide, please. Okay, so what should you do on arrival and maybe even before you arrive at your place of service to be prepared to address malnutrition. So before you arrive at your duty station, one thing you can do is be aware of the clinical signs and symptoms of nutrient deficiencies. Have a resource to identify those. My husband likes the Harriet Lane Handbook, he told me, for this. So keep that in mind. Maybe take one with you. And find out from the local colleagues what they know about diagnosing malnutrition in the patient population. Be sure that you can learn from them. Ask how they address it. Do they address it therapeutically? Do they screen for it? And you can also ask them what nutrients are commonly missing from the local diet. And you should know how these particular deficiencies manifest themselves, because then you know what to look for. So next slide, please. Find out what kind of services there are in the hospital where you are working. Are there some nutritionists? And here's a good example. The Cameroon Baptist Convention has actual nutritionists that work in every hospital and in every clinic in their system. They have 5 or 6 hospitals, I think 6 now, and about 25 or 26 clinics. And these nutritionists are women who've been trained. Well, I think they even have a few men now have been trained. They have about 3 to 6 months of actual book learning and training. They're also trained for HIV because their program came out of the Prevention of Mother to Child Transmission program at the Cameroon Baptist Hospital Services. But they are trained for 3 to 6 months, and then they go and have actual internships, just like I did as a dietitian. Only about 3 to 6 months in the hospitals there. So they don't have that underlying understanding of maybe pathophysiology and biology, microbiology that I would as a dietitian, but they are pretty good and they know what to do about NCDs. They know how to instruct the patients. And best of all, they are from the culture. So they know what the diets are like. They know what the problems might be for the patients to be able to get the diet that's healthy. And they're just excellent resources. Now, of course, not every hospital that you serve at will have anybody like this, but ask around and find out if there's a nurse that kind of specializes in nutrition, or there's one of the doctors who has a special interest in it, and they'll be able to give a lot of help to you. Next slide, please. So know what vitamin and mineral supplements, we're down on point 4 there. Know what vitamin and mineral supplements and protein calorie supplements are available in your hospital. Is there food available for the patients or the families required to provide all the nourishment for the patients? Oftentimes, almost all mission hospitals we've been at, except I think one, the patients were required to bring a family member who could cook for them, and they designate a spot at the hospital grounds and the families can cook there for the patients. But sometimes they'll send, say, a young male cousin, or they might send an older person, and say this young male cousin doesn't even really know how to cook. So what's he going to do? He's going to go to the local market and buy whatever he sees there, white bread and orange juice or something like that, and bring that back to the patient. So it's a good question to ask to find out is how are these patients fed? And as far as the vitamin and mineral supplementations that's available, when I first arrive at a new mission hospital, I like to go to the pharmacy and ask them what do they have in stock. Oftentimes it will be very simple. This is from Bingo Baptist Hospital in Cameroon, and they have a real pharmacist there, a couple of them in fact, and they have quite a few selections. But it's good to know what you're going to work with if you see some patients that have nutrient deficiencies. You'll know what you can actually prescribe for them. And of course, every time you go, every hospital will be different. And every time you go to the same hospital, we were in Cameroon twice, and the formulary was different each time. So it's just a good idea to go and ask. And if you're really serious about treating malnutrition, oftentimes they'll even type it up for you. I did this one myself, but oftentimes they'll type it up for you. So my idea is to go ward by ward, just so I have a little bit of organization for my thoughts. And I hope that you can extrapolate some things from my case studies that I'll do so that when you have similar patient encounters, you'll have some good ideas, some tips. And as to DART employments or deployments or other deployments like that, I hope you can glean some ideas, even though most of it is going to be talking about Mission Hospital. So next slide, please. Oh, I see. Go one. I'm sorry. This was the formulary, and I forgot to say next slide. So this is the formulary right here from Bingo Baptist Hospital that I was talking about to get them to type up for you, or you can find out yourself. So go ahead and next slide. Okay, so let's start with the newborn ward. And basically one thing I want to say about the newborn ward is promote breastfeeding. Promote, promote, promote. There are many reasons not to send babies home on formula. The Lancet Breastfeeding Series says the scaling up of breastfeeding to a near universal level could prevent 823,000 annual deaths in children younger than 5 years. Diarrheal illness could be reduced by half, and at least 1/3 of respiratory infections avoided by moms breastfeeding. There would be a reduction in hospital admissions for diarrhea by 72% and respiratory infections by 57%. So it's absolutely imperative, especially when you're working internationally in low and middle income countries, mostly low income countries for sure, that women breastfeed. If you try to send a baby home on formula, generally the baby will be back soon with diarrhea or just poor growth because the families cannot afford formula. It's not like here where you can go to the WIC program, the Women, Infants, and Children Nutrition Program, and get free formula. They just don't have it, and most families just could not afford it. So there are very few reasons why a woman cannot and should not breastfeed. Maybe HIV, even then, the Ministry of Health in your country and the nurses in the ward should know this, the doctors should know this. The Ministry of Health sets standards about women with HIV. Should they breastfeed? Should they not? So you'll find out what those are. But generally, in a place where there is no clean water and it's very difficult for a mom to make formula that is safe, the recommendation is that the moms go ahead and breastfeed. And then, of course, you try to get the moms on ARVs, but sometimes that doesn't happen, or she won't be able to get it all the time, that kind of thing. But at least up to 6 months, that's the recommendation generally. The majority of medications are safe in breastfeeding. I know in the States, some doctors will encourage the mom to stop breastfeeding when she goes on a medication, and there are very few that are unsafe for breastfeeding. So there's a LactMed database, and I put that in my references, and you can look that up to see which medication you might possibly prescribe would be unsafe. Cleft palate, of course, usually requires a cup or a feeder, but you can have the mom express milk, and that would be just the best way to give it to the baby. So I always tell people, when you're going to prescribe something, when you're overseas especially, give it the AFASS test. Is it affordable to the family? Is it feasible? Is it even possible? Is it acceptable? You're gonna tell them to do something, but then because of their culture, they're not going to want to do it. Is it safe, and is it sustainable? So anytime you might think of providing formula, give it the AFASS test, and you'll find out that it's probably not going to meet that test to give a baby formula in low and middle income countries. Okay, next slide, please. Here's just an example, one of my first stories here. I was consulting in Haiti, and the organization, the NGO I was working with, took me to this community-based management of malnutrition group of moms that they gather. These babies had been determined to be malnourished, and so they want to feed them, provide them with extra food and nutrition so that the babies can grow. There were 6 babies. They're not all shown in this picture here, but 6 of them were present at the meeting, and of those, 5 of them had absent mothers and were not able to be breastfed, either from death or from desertion. The mothers were not present, so these family members were trying to improve the nutrition of the babies and trying to feed them and help them grow. But without breast milk, it's just very difficult in countries like this. Next slide, please. So, and contrast that with this. Apply the ASS to this situation with breastfeeding of triplets. So this is where the mom lived. You can see the picture in the hut on the left. This mom had triplets at Bingo Baptist Hospital. All were born healthy and were able to go home. They were born early, about, I think, 35 or 36 weeks. But the mom managed with family help and with home visiting support from the hospital, bringing her food, encouraging her. She was able to breastfeed those triplets. So I don't know, they were about 3 months old, I think, in this picture, and I don't know how much longer she was able to, but find out what your nurses recommend if a mom can't breastfeed, but try to get them to breastfeed, because if a mom of triplets is able to breastfeed, then just about anybody can. So there is some potential for using animal milk or powdered milk with nutrients added. And in some places, they can give a thin gruel if nothing else is available and there's no wet nurse. Often they'll try to find another family member who can be a wet nurse for the babies. But just know that when you try to apply the ASS to this situation, people would think this is just really impossible for this mom to make formula, to afford formula for these 3 babies. And so what a blessing that she was able to breastfeed these babies. Next slide, please. Okay, so now on to pediatrics. Determination of malnutrition in children. Of course, any child with edema, reddish or thin hair, that's immediately suspect. And severe acute malnutrition, you will see it come into the hospitals at times. And the nurses that are in those hospitals will usually know the WHO protocol for severe acute malnutrition. The doctors will know it. So if you want a good presentation, you want more information on that, Julie Tanaka, who's the Samaritan's Purse Senior Technical Advisor for Nutrition, did a really excellent presentation on the Samaritan's Purse International Health Forum in 2013 on severe acute malnutrition. So you could look at that one. I'm not going to talk about it today because it's more complicated than I have time for, but there is a good protocol from the WHO and you could implement that. And like I say, on any kind of a ward that's a pediatric ward in an international hospital will generally know that protocol. So when you go on a DART, this happened to me, actually, if you're on a DART, there should be a UNICEF clinic, especially in an area where it's known that there will be malnourished children, or there will generally be a UNICEF presence, and they will have a clinic that you can refer these children to. So you just have to ask that question. Next slide, please. Okay, so here's a picture of a child, it's probably about 2 years old actually. And what it usually means when you see a child like this, unless there's just no food in the area, it's a refugee situation or an IDP situation, it usually means that something's happened to the mother, because normally you'd want the mother to breastfeed for up to 2 years. That would be the safest thing for the child, the best thing to provide good nutrition for a child. Not totally breastfeed, obviously, but you start introducing food at 6 months. But generally what will happen when you see a baby like this, it will mean that another child has been born and the baby has stopped breastfeeding this one. And it is possible for moms to breastfeed 2 babies, but it usually doesn't happen. So if these babies become ill, one that looks like this, they're going to need to be hospitalized or go to a refeeding center. So find out your resources. Next slide, please. Okay, so when you look at these children here, would you recognize them as being malnourished? They look fairly adequately, they're not fat, of course, but they look average weight. And when you see all 6 of them there, you'd think, well, they're all from the same village. They're all probably okay. But these children are actually quite stunted, and they're from Guatemala, which has a high rate of stunting. So they're all 9 years old, and the line above them represents the average height for a 9-year-old. So there are many places in the world where all the children are stunted, and it becomes a thing of people don't recognize that the children are stunted because they all look that way. So you need to know that there are charts that exist by the WHO that will tell where children should be at a given age by their Z-score, it's called, their weight for height, their height for age Z-score. And that's what you want to look at. So oftentimes the children will be weighed but not measured. And so it's really important that children be measured and that you compare them with these WHO charts, and they should be available in most hospitals. So just know that that's important, because you know then that these children are probably nutrient deficient, especially micronutrient, especially zinc deficiency will contribute to stunting. So next slide, please. Okay, so does this look like a bad case of diaper rash? That's probably what on first glance you might think. However, this is actually zinc deficiency. And there's also a skin condition called flaky paint dermatosis, where the skin is kind of darker and flaking. And the child has a zinc deficiency probably because he's had a number of cases of acute diarrhea that led to zinc loss. So look for these types of skin conditions. It's not necessarily in the diaper area. It might be on their face, the arms, the chest, but just have an idea of what some of these conditions look like. There's a high prevalency of zinc deficiency in a population where the children are stunted. And if diarrheal illness is common, you're going to have a high rate of zinc deficiency as well. Next slide, please. So how are you going to treat this? You can see that zinc is only available in the pharmacy in 20 milligram tablets. Well, it's going to be difficult to get a baby to take a tablet like that. So you're going to have to figure out, the nurses will know, ask the nurses, how do they get the children to take these tablets? They'll help you with that. And the WHO is now recommending a 10 to 14 day course of zinc treatment with every acute episode of diarrhea. So children above 6 months of age, it's a 20 milligram tablet a day, and 10 milligrams for children under 6 months of age. So how are you going to prevent this? If the mom comes in and you give them this treatment of zinc, mom comes into the hospital, you don't want the child to have to come back to the hospital every time they have diarrhea. So what will you tell the mother? Well, some clinics in some of these countries know about this protocol. And if you encourage the mom to take the child to the clinic every time she has diarrhea, hopefully they'll get zinc. Hopefully they'll get this zinc protocol, but they may not. There may not be a clinic available. There may not be zinc available. So if not, another idea is that you can look for these inexpensive packets of ORS mix, the oral rehydration solution. They're often available in little inexpensive packets in the market, and hopefully they'll contain zinc. Not all do, but that's pretty much now the standard, is that zinc is in these ORS packets that you mix with water. So the nurses and your physician colleagues will know about this if they're available in the markets generally, and mom can be encouraged to mix a packet in juice or water every time the child has diarrhea every day of the diarrheal illness, and that should help. That now mom should only be doing this when the child has diarrhea. You wouldn't want her to give. Some people think Pedialyte is a great thing, and I'm sure they think this ORS water, once you tell them to do it, they're going to drink it all the time. But we do know that long-term zinc supplementation can cause problems with copper deficiency. So make sure that's clear. Next slide, please. Okay, so this is the malnutrition infection cycle. Many of you have probably heard of it, but basically just talks about children, how they can become severely malnourished. And if they're malnourished, then it just creates a bigger and bigger downward spiral where the children have muscle wasting and weight loss, nutrient deficiencies because of poor nutrition, and then their immune system becomes impaired, and they have a poor ability to fight any infections that they might get. They have increased vulnerability to infections then, and increased nutritional needs because of this, but yet they're not absorbing very well the nutrition that they're given. So even when refeeding begins, they often will not gain weight. And that's becoming, there's a lot of research by the Gates Foundation and others about why these children who come in severely malnourished, even when you start to refeed them, they will not regain weight and health as you would expect. So next slide, please. So here's one of my stories too. This baby came in malnourished, very malnourished. The mom brought her in, very worried about her. She was tested for TB, HIV, and multiple bloodborne pathogens, stool tests, everything was negative. And meanwhile, this mom was faithfully doing everything she could for this baby. Everything we encouraged her to do, she would do. Finally, they put a tube feeding down this little girl because she just was refusing to eat. She was so weak and getting weaker. We tried adding extra vitamins to the tube feeding, even though there was a standard vitamin powder in the tube feeding. She continued to lose weight. And then they put her on antibiotic after antibiotic in an attempt to try to find something that would help her turn the corner. Finally, we added yogurt to the tube feeding and hoping to improve her gut microbiota or something. We were just trying anything we could think of, and maybe that would improve her nutrient absorption. So this mom was just a beautiful believer, and she was so faithful. She did whatever we asked to try to get this little girl to gain weight. She was borrowing money from relatives to try to keep the child in the hospital because she knew that if the child went home, she would die. So we were praying for her, with her. The chaplains would come to pray. And after 3 weeks of nothing working and the child continuing just going downhill physically, mom was running out of courage and the child just continued to go downhill. My husband was there at the time and the local expat physicians, and they decided at least they should try TB drugs as a last resort. But it's often a struggle to get them, not often, but always a struggle to get the TB cocktail, pediatric cocktail, or any TB drugs approved when there's no positive PPD. So they pretty much begged and said, we don't have anything else to try for this little girl. Let's give her the TB drugs. So a course was begun, and literally it was not even 5 days, and this little girl began to sit up and smile and play. I'm going to get emotional about this because it was so dramatic. And you can see on the picture in the right there, after about a week, the mom was ready to take this girl home. She had to borrow more money to bail her out of the hospital. In fact, she had to sleep on the floor in the pediatric ward, even though the girl was ready to go home, because they didn't have the money to pay for this extended hospital stay. Well, what was it that got missed? My theory and my firm belief is that this child was so malnourished that she was unable to mount a positive immune reaction to the MANTU, the PPD test. So this, to me, is an example of how malnutrition, when unconsidered, can affect a patient outcome. And this is possibly an extreme example, but I'm sure there are many children who are malnourished who would be in this same situation, that they just could not even mount any kind of immune reaction enough to make a positive PPD. And so think about the other implications for their health that has. So we need to figure out how malnutrition is figured in the equation for some of these diagnoses. And go ahead and move the slide. Thank you. And here's another interesting case. I was making rounds with Maybell, one of the nutritionists in Cameroon, and we saw this little baby who was just very shrunken and laying on its back and kicking its legs. It was just totally dehydrated. But I thought, this baby looks pretty strong. So I put my fingers out and the baby was able to grasp it. Come to find out, Maybell, my Indigenous colleague there, was able to find out from the mom that the father had left the mother and the mother had quit breastfeeding and wanted the baby to die because the dad had left. So that's a good example of using the wisdom of your Indigenous colleagues for this kind of thing. So next slide. So, and often in the pediatric wards, there's some ready-to-use therapeutic feeding that might be donated by UNICEF, but just be really careful about using that. There's a lot of pitfalls. If you get the patients up to a weight where they can go home, but they go home to the same situation they were in before, then they're going to be right back. So you need to have someone teach the patients how to feed, the parents how to feed the child. And we also had examples of the mother or who's ever the caregiver eating the RUTF instead of the ready-to-use feeding, instead of giving it to the child. So another thing I wanted to show you about this slide is if you look all the way to the back, there's a door open there, and that is a Burkitt's lymphoma ward. And there was a doctor who would come from South Africa and treat these patients. He gave me one of the better ideas of my entire career, and that was that he would prescribe for the patients that their parents should give them an egg a day. He recognized that nutrition was really important, that these children were often low on protein in their diets. And so he prescribed on a piece of paper, along with their other medications and the other things the parents were to do, 1 egg per day. So I thought that was very clever, and that's something that you can take with you as well. Next slide, please. So here's an example of a mom. It's low tech, but it's affordable and feasible, affordable to most parents, not always, but it's sustainable, just a boiled egg. It's healthy. So write it down. Next slide, please. So this is some criteria for adults' diagnosis of malnutrition. When you go to the adult ward, you're going to see people that you know are malnourished. Here's just some phenotypic criteria that you can apply. If they've lost 5% of their body weight in the past 6 months, or 10% beyond 6 months, low BMI, reduced muscle mass, and nowadays they're starting to have tapes for adults. It used to be it's only children that had these MUAC tapes, but now they're starting to develop MUAC tapes for adults. Maybe they'll even have one in the hospital that you're working in. And of course, reduced food intake or assimilation is a problem. These are the etiologic criteria. Reduced energy, less than 50% of energy requirement for greater than a week, and a reduction for 2 weeks. Any reduction in food intake, and of course, any GI condition. So acute inflammatory disease, chronic disease related, any of these things are etiologic criteria, they're called. And this Global Leadership Initiative on Malnutrition has stated that if a patient has one of the phenotypic criterion and one etiologic criterion, they're considered malnourished. So calf muscle is another interesting way you can determine if you carry around a measuring tape that's a soft tape like you'd use for sewing. You can measure someone's calf muscle in adults, and they say the cutoff that I found, I think there hasn't been enough research done about this, but it's 30.5 centimeters. So if a person has a 30.5 centimeter or less calf muscle, you can expect they might be somewhat malnourished and have a low muscle mass. There are many nutritional assessments you can use. If you're used to using one in your hospital at home, you could use that one there too. Grip strength, hand grip strength is a possible one. Of course, you're not going to have the actual tool, but you could just have the person grasp your hand, maybe 2 or 3 of your fingers, and see how strong they are. And is actually a pretty good low-tech way of measuring muscle mass. Next slide, please. Okay, and so I just wanted to list a few potential causes for reduced food intake, and most of these you would know, but poor oral health is a real big one. In low and middle income countries, people just don't see a dentist. There aren't very many dentists, and often dentition is a big problem. They might have abscesses, they might be missing all kinds of teeth. So that's one that you can look for right off the bat, is check their mouth, see how they're doing with their dentition. Of course, dysphagia, dysgeusia, anorexia, all these other things. Psychosocial, these are ones that you're going to have to rely on your colleagues from the country there, your local colleagues. The family might be unwilling or unavailable to feed these patients. You're not sure, you won't be able to get that out of the patient, probably, because they're going to tell you what you want to hear. You might need to call the chaplains to get to the bottom of it. Country medicine is another one. Traditional treatments with some shamans or witch doctors, they will tell people don't eat when they have certain diseases, especially children who might have diarrheal diseases. They might tell them to the mom, don't feed them. So just be aware that that's out there, and you can even have your colleagues ask, and they'll be able to get out of the patients more. The patients will have come to the hospital as a last resort, and they're embarrassed to tell that they've already gone to the witch doctor or the country medicine doctor. So that's another one. Next slide, please. All these disease states, of course, will affect the assimilation of food and nutrients. Chronic alcoholism, that's one you'll see for sure. Cancers of the GI tract, inflammatory bowel disease, all these things will affect the assimilation of food and nutrients. So just be aware, anytime someone has one of these, they're probably going to be malnourished. So next slide, please. Acute inflammatory states, any disease or trauma that induces elevated body temperature, you're going to increase the metabolic rate, your heart rate, the catabolic processes are always going to increase your need for calories, protein, and micronutrients. So anyone that's had burns, and those are frequent overseas too, children falling into the cooking fires or people being burned from a lot of people will cook by the side of the road with highly flammable things beside wood. They will cook with something that might just explode, and so they'll get burned. Infection, sepsis, obviously. Poisoning, that's something we don't think about so much, but there are a lot of environmental poisons because people just pour things into the ground. It seeps into the groundwater, so they could be toxic that way. And then, of course, snake bites, something we don't see here a lot, but over there they have definitely deadly snakes. So next slide, please. So your part as a provider is you need to communicate to your local colleagues your concerns when you see someone who's malnourished. Ask their thoughts and ask what they suggest. Don't come in there as the Western doctor and thinking you know it all, because you don't really know about their culture and you don't know about the foods in their area. So make sure you always ask your local colleagues. Be a learner. Discuss with them that the patient will probably come back and be hospitalized again if he or she continues to be malnourished. So if possible, you could modify the medication regimen if there's problems from that. But the problem with that is the formularies are small. There aren't many choices. You can add vitamins and minerals to the patient's therapy. And oftentimes they'll be able to afford those. If you send them home on certain vitamins or mineral supplements, they'll be able to afford those. If you encourage them that they're very important. Talk to the patients and the family about the need for better nutrition and increased calories at home. And then last but most importantly, call on the national staff to provide culturally appropriate advice. I keep emphasizing this, but I can't emphasize it enough. We don't know the nutrition availability in the food availability in the area, and we don't know the culture about feeding people. Do the children get fed last? Do the older adults get fed last? That kind of thing. So remember that Western solutions are not always the best. Okay, and so call on the resources. Know what resources are in the hospital: nutritionists, nurses, social workers. Sometimes they'll have social workers. They almost always have chaplains. Anywhere you'll go with World Medical Mission, there will be chaplains available. And those are people that you can definitely call on to help you out. Sometimes you can have a chaplain come and talk to a patient, and they will get some information out of the patient that you were not able to get, or even the nurses were not able to get. They'll sit by the bedside and talk to them, and that's just super important. So try to get the PT people, if there are any, in, because oftentimes those with low muscle mass, we know that's related to mortality. People with low muscle mass, have the physical therapist come in and teach simple exercises, or have the nurses do it. You teach the nurses and the nurses can do it. COPD patients, often it is a cultural thing not to make the older people do what they don't want to do. Excuse me. If the older person wants to lay in bed and doesn't want to get up, which is common here as well as there, the family will not make them because they have the patriarch or the matriarch of the family. So you'll need to express to the family how important this is, and then call in the PTs to have them teach what to do. And the other thing is that you'll want to have the nurses or you observe to see, after you give them some tips, to see if this is really happening before the end of the hospital stay. So next slide, please. Oh, that one's that. Sorry, I forgot to tell you. Next slide. Okay, so this is an example of the nutritionist talking to the family. So yeah, now we're on the right one. Here's just a quick tip that I found from working with AIDS patients. I had to try to think of something that could make these HIV patients, AIDS patients gain weight. So I was looking for a source of medium chain triglyceride oil, which is easily absorbed and has lots of calories, of course. If the HIV patient is not doing well, oftentimes they won't even absorb the foods well. And sometimes oils, fats, which you want to give for calories, will cause steatorrhea. So I was reading in some analyses of palm oil and coconut oil, and they do have a lot of this medium chain triglyceride oil in them. So that's something that you could encourage. Add to their foods, have the patients add to them foods. Yogurt is another one. Any kind of fermented foods are a good source of improving the microbiota in the gut. So the probiotics. So go ahead and encourage those. So next slide, please. So non-communicable diseases, basically, we all know about those from being here in the States, but just know that what you want to do is be aware of the principal nutritional factors that are complicating these NCDs, and then have the nurses instruct the patients. Find one or two things. I've known as a dietitian for over 40 years, I will say that if you try to give the people too many instructions and too many diet changes, they'll give up and not do it at all. So find the one or two things. Are they salting all their food? In the Bahamas, when I was working there with DART, they called me in to see one patient because they knew I was a dietitian. And the doctor told me, I don't know what this guy is doing, but he is blowing up. He's got congestive heart failure. His feet were huge. His legs were huge. Come to find out, he was putting garlic salt on almost all his food. So I worked with them. We talked about that and the importance of that. He really didn't want to have to come back to the hospital looking and feeling like he did. So that was one thing that we did that we could talk about that will make a huge difference for that guy. He can change to garlic powder instead of garlic salt, and it will take him a while to get used to it, but he was motivated. So we do know that in humanitarian relief situations, taking care of NCDs has been neglected, and it's going to start to be it's coming to the forefront as being more important. So the other thing I would say is don't tell your patients that there's some drug in the West that can take care of their problem, but we don't have it here. I had actually my Cameroonian friend took her husband into an outpatient clinic, and the doctor told her, well, in the States we have, he was a diabetic and not doing very well. And the doctor, it was one of the Western doctors that was visiting, probably through World Medical Mission, I don't know, but told my friend, well, in the States, we have a drug called Trulicity, but we don't have that here, but that would really help your husband. So of course, what did Florence do? She immediately got on WhatsApp and asked me, could I get Trulicity for her husband? So just be sure that you don't ever bring in what Westerners would do, because they won't be able to get it there. So I see that my time is going by quickly, but let's go ahead one more slide here. So this just talks about use the hospital experts. This actually is a diabetic expert at the Cameroon Baptist Hospital. He actually doesn't do what we motivational interviewing, have the patient set goals. No, he shakes his fingers at the people and tells them, you better do this or that, or your disease is going to get bad and you're going to get amputations. And we think, oh my goodness, shouldn't be saying that. But culturally, that's the way they do it. He's got a white coat on and he can do it that way. So refer patients to anyone like this who you is available in the hospital. Just know that culturally, it's just better if there's one of their own talking to them about it. So next slide, please. Surgical ward, you don't have time. You can see all these people waiting here to have surgery. Current opinion in anesthesiology says as many as 2 of every 3 major surgery patients are malnourished preoperatively. A diagnosis rarely made and treated, even less frequently. Unfortunately, perioperative malnutrition is perhaps the least often identified surgical risk factor and is among the most treatable to improve outcomes. So really important, you can't do a full nutrition assessment when you're in a surgery clinic, but screening is doable. There's a perioperative nutrition screening tool that's just basically 3 questions. Have you had a 10% unintended weight loss in the past 6 months? Are you eating less than 50% of your normal dietary intake for the past 2 weeks or week? And you can weigh and measure, is your BMI under 18.5? Well, if that's the case and the patient is waiting for an elective surgery, send the patient home for a week or 2 and give them the egg RX and vitamins and minerals from the pharmacy, and have them follow this regimen for 2 or 3 weeks, as long as is reasonable given the problem that they have, and then have them come back, and that will definitely improve outcomes. So go ahead and next slide. After surgery, of course, if they have emergency surgery, you're gonna have to, you'll have to manage their nutrition post-operatively, and it's really important that you do so. Starting a tube feeding could be a problem. It's very difficult. It may not be AFASS to discharge a patient home with a tube feeding. So just remember that there are a few families that are capable. If you have a large bore feeding tube, they'll be able to do this, but otherwise, try to find a different solution before you would send them home. And even in the hospital, if you can go to the next slide, you'll find that this is where the tube feedings are made. This is where the TPN is mixed. There was actually a couple trials of TPN in Cameroon while I was there, and 2 of them did not go well. So just be aware of that there just are not going to be the same resources as you're used to. Try to think of a non-Western solution with the help of your colleagues. They'll know what they normally do for these surgery patients that really need something that we're used to giving easily in the States, but they may not be there. So go ahead and next slide. Here's the wound ward, same thing, very malnourished. While the patients are there, see if you can address their protein and calorie deficits. If the patients are poor, some of these patients will stay 3 months, 6 months, 9 months because they just are so poorly nourished and the wounds don't heal. My thought is they could probably get out more quickly. They could be released if they would have decent nutrition, but again, the families are feeding them. Next slide, please. So utilize the hospital resources. If this woman here, HIV positive, paralyzed from the waist down, and had a decubiti that was very large on her coccyx, it's going to be very difficult for her to heal with what her husband could afford. He'd already spent a lot to have her there. Call in the chaplains, call in the nutritionists if there are any. The chaplains often will have some money that they can give to families so that they can have a better diet for their patient that's in the hospital. Make sure you give them some zinc, vitamin C, vitamin A. If I ever get to go back to Bingo Hospital, I'm going to do my goal is to do some research, a trial in the ward of giving some of the patients some vitamin C, vitamin A supplements and an egg a day to see if we can make a difference in that. So basically, to end up here, work together on all these things with your local colleagues. That'll be teaching for them, and it will also be a learning experience for you. Cultural humility is really your best friend, and that'll provide the best outcomes for the patients and staff. If you in any way make the local people or staff feel like the Western doctor is far superior to their own local doctors, you will have done great damage. So don't do that. I one time had one of the nurses in Cameroon come to me and say that one of the Cameroonian doctors had asked to have a nutritionist come see his patient, but he wanted the white nutritionist. And of course, that was me. So at that point, I had to rethink whether I needed to be going on rounds and that kind of thing. And obviously, that's what you're going to do when you're there, but just be really cognizant of how you're coming across, and maybe even teach your colleagues and have them do the actual talking to the patients. So I just hope that this presentation, I see it's gone on longer than it should have, but I hope it's been valuable to you. And I do have 4 slides of references and some resources at the end of the presentation. So you're always welcome to email me when you're on the field or anytime, or call me. I don't know if my phone number is available, but I'd sure be happy to talk to anybody about this. As you can see, I'm quite passionate about it, and I've gone way over time, but I hope there's a few questions I can answer, if that's possible, Lance.
Yes. Laurie, thank you so much. That was a great presentation. You brought up so many points. One, I just think when you talked about sort of the triad of malnutrition, so many countries are becoming more developed. And with that, unfortunately, there's westernized diets with obesity and metabolic syndrome, and and associated with that is real morbidity and mortality. So I think we have to take that as seriously as macro and micronutrient deficiency. So that's a very valid point. And one other point, and I'll get to the questions, is I love that example you gave of the little girl that had tuberculosis, and that was like subclinical. We didn't recognize it, but malnutrition and disease entities are so intertwined, and so we have to really think about both processes in the process of bringing healing to our patients. So that was a great example about malnutrition and tuberculosis. We always need to think about that. And then I'll just say you get a A+ for talking about the nationals and the chaplains. So often when we go there, we don't think about these resources. And I'll just close with my statements with just saying, I love what you said about cultural humility. That is the approach we always need to take. And we're going to learn as much or more than they are. So I like that term, cultural humility. Laurie, with that, Alan Sawyer says, what are good public health nutrition education programs you have seen to educate large groups in limited resource countries? He said, these problems are so ubiquitous around mission hospitals.
Yes. Okay. You want me to address that?
Yeah, so just what if you have a few examples of good public health nutrition education programs?
Okay, well, sure. Well, number one is a lot of these hospital systems, if they're a hospital system, will have clinics in outlying areas, and often they don't even have a trained nurse in the clinic, though some of them might. But these small clinics and more localized, so that people can reach them, they're more likely to take their families there. So even if you just had a small building in a church or a small room in a church, and you had a person who was trained, there are all kinds of programs now for training local people. They give them small amounts of training, what we would consider small amounts, but they'll maybe 6 months of training on basic nutrition and basic medical procedures and diagnoses, not so much procedure probably, but diagnoses. That's also always excellent to have something closer to the people so they don't get so sick that they have to come to the hospital. The other thing is there are now community health volunteers, they're called, or community health educators they'll choose like a mother from they'll let the local people choose the mother, and she will be the point person, and she will come to a training and then go back to her village and teach the women in the village. They'll have them gather in a group, say once a week or once a month, and she'll give them some teaching, and then she'll go back and get more teaching from the group, from the main provider of the education, and then she'll go back. But once again, she's a cultural resource. She's a person from their village, and she will know what the problems are and how to teach these women. So that's always good. The community health education, community health evangelism, or community health education is just an incredible program. So look up CHE, Community Health Evangelism, and that is an excellent, excellent program.
Well, thank you. Heather Fowler from Papua New Guinea says, excellent. Can't agree more, with emphasis on asking what is seen in a region and what is available. We have local calcium deficient rickets, or local calcium deficient rickets. Let's see, question number 2, Martin Nginja, pardon me. It says, hello, I haven't deployed in a DART mission yet, but was inquiring if stabilization centers for severe acute malnutrition, or children with severe acute malnutrition, are part of field hospitals. I can answer that one. It really depends on the DART deployment. I'm sorry. It depends on the DART deployment. Some DART deployments may not be associated specifically with acute malnutrition, such as after an earthquake, but certainly more like complex emergencies, or where we're in a refugee camp situation, will certainly address severe acute malnutrition. So yeah, it depends on the DART deployment. And then the last question, Laurie, it says, Rob Thames says, thank you so much. Will slides be sent out? Many compliments and thank you. So I can answer that one too. Yes, if you'll look, we will definitely, you'll be receiving a subsequent email that will contain this presentation, but also if you go to health.samaritanspurse.org, you'll see our archives of presentations. This one will be archived with the others, and encourage you guys to look at that. CME is available. So yes, we'll be sending out a link with Laurie's presentation. And just want to thank you, Laurie, so much for this, again, outstanding presentation. Our next webinar will be Wednesday, February the 10th, with Dr. Kelly Faber. Kelly is located in Hospital of Hope in Togo. She's going to be speaking about care for the premature infant in low and middle income countries. So please join us with that. Before we conclude, I just want to make one more comment. I've never done this before, but behind the scenes is our communications department, specifically Dustin Petrie, Curtis Cosby, and Brett Stevens. They're behind the scenes, every presentation, making this presentation go seamlessly, and they do an outstanding job. So I just want to give them a real shout out. With that, you guys, thank you so much, and have a great day.
Thank you, Lance.
Thank you, Laurie.